As part of Module 6, it is now a time to discuss self-harm. This is a very sensitive topic because some of you have loved ones who were probably affected by intentional or unintentional self-harm. We will specifically focus on Chapter 16, which is suicide prevention. We will review self-harm and suicide assessment, including the mental status examination, the warning signs, and client education. Suicide is not classified as a diagnosis or disorder, rather, it is a behavior. The term originates from Latin words meaning one's own killing. Many religions consider suicide a sin and strictly prohibit it. Additionally, cultural norms and attitudes significantly shape an individual's beliefs about suicide. While suicide touches the lives of all ages, ethnic, and racial groups in all parts of the United States, some populations are considered at higher risk for suicide, including American Indians, Alaskan Natives, active and veteran military members, LGBTQ+ individuals, people in prison or child welfare settings. A complex interaction of factors such as mental illness, substance abuse, painful losses, exposure to violence, and social isolation are all influential in increasing these risks. In the past decades, many state legislatures have debated the acceptability of physician-assisted suicide. It is legal in all United States for an individual or their power of attorney to refuse life-preserving medical treatment. At the time of this publication, Oregon, Montana, Vermont, Washington, California, Hawaii, and Colorado are the only states that have legalized physician-assisted suicide. In the field of psychiatry, suicide is considered an immoral act associated with mental illness, and most commonly, but not exclusively, with depression or bipolar disorder. Epidemiological factors of suicide. In 2017, more than 47,173 people died by suicide in the United States. The numbers continue to climb, despite nationwide attention to suicide prevention. Recent statistics have established suicide as the second cause of death, behind unintentional injuries, among young Americans ages 10 to 34 years, the fourth leading cause of death for ages 35 to 54, the eighth leading cause of death for individuals ages 55 to 64, and the 10th leading cause of death overall. Historically, the suicide rates among military personnel have been lower than in the general population. However, since the Iraq War, more soldiers died by suicide than died in combat. Confusion exists over the reality of suicide. Some of the more commonly accepted myths relating to suicide include: the idea is that people who talk about suicide do not commit suicide. In reality, 8 out of 10 people who kill themselves have given clues and warnings about their intentions. Women attempt suicide more, but men succeed more often. Successful suicides number about 70% for men and 30% for women. This has to do with the lethality of the means. Women tend to overdose, men use more lethal means, such as firearms. Transgender individuals are also a high-risk population for suicide with an alarming 41% lifetime prevalence. Historically, suicide rates among Protestants and Jews have been higher than Roman Catholic or Muslim populations, but the degree of orthodoxy and affiliation with one's religion may be an important variable. A systematic review of research on religion and suicide risk found that while religious affiliation is not protective against suicide action, it is protective against suicide attempts, and that religious service attendance is probably protective against suicide. Some researchers stated that religious affiliation is associated with a decreased risk of suicide in both general population and those with mental illness, independent of available social support systems. Individuals in the very highest and lowest social classes have higher suicide rates than those in the middle classes. Suicide rates are higher in rural areas and with a twofold greater use of firearms as the means. Low education and unemployment significantly increased the prevalence of attempts among young adult men and women with suicide ideation. Previous attempts are a leading risk factor for eventual suicide. With regard to ethnicity, statistics show that whites are at the highest risk for suicide, 15.85, followed by American Indians and Alaska Natives, 13.42, African Americans, 6.61, and Asians and Pacific Islanders, 6.59. Recent research has highlighted trends that illuminate issues of concern within specific ethnic groups. First, while suicide rates among whites are higher in adults and the elderly, within the Native American community, young adults have a higher risk for suicide than any other ethnicity and higher than the general population. Another recent study looked at suicide trends in school-aged children under the age of 12. A significant finding was that suicide rates for Black children aged 5 to 11 years of age nearly doubled from 1993 to 2012, while the overall suicide rate in this age group remained relatively stable during the same time period. The majority of people who die by suicide have a diagnosable mental illness, most commonly depression, bipolar disorder, or a substance use disorder. Individuals who have been hospitalized for a psychiatric illness have 5 to 10 times greater suicide risks than those with psychiatric illness in the general population. Trauma, brain injury, sleep disorders, and HIV/AIDS confer a twofold increase in risk of suicide. Severe insomnia is associated with increased suicide risk, even in the absence of depression. A thorough suicide risk assessment should be conducted for anyone seeking mental health services. The use of alcohol, particularly a combination of alcohol and barbiturates, increases the risk of suicide. Withdrawal from stimulants increases suicide risk as the person begins to crash. Psychosis, especially with command hallucinations, hearing voices telling one to harm or kill oneself, increases risk, as does having a chronic painful or disabling illness. Several studies have indicated a higher risk factor for suicide among LGBTQ+ individuals even in youth in grades 7 to 12 according to a recent CDC report. Higher risk is also associated with a family history of suicide, especially in a same-gender family, and with individuals who have made previous suicide attempts. Roughly equal numbers die by suicide on their first attempt, therefore, all individuals with suicide ideation should be assessed carefully for risk factors and warning signs. Some of the risk factors that lead to suicide entail psychosocial factors. The latter encompass feelings of hopelessness, intense emotions, like anger, rage, and guilt, challenging interpersonal relationships, developmental stressors, particularly in adolescence, and a personal history of trauma or abuse. When assessing a client's suicidal ideation, it's crucial to differentiate between ideas, the client's thoughts related to suicide; plans, specific intentions or strategies for self-harm; attempts, behavior, actual self-injurious actions. Additionally, when a client has attempted self-injury, it's essential to discern between suicidal self-injury, related to suicidal intent, and non-suicidal self-injury, which may serve other purposes. Also, when assessing a patient for suicide risk, consider the following factors. Plan. Does the patient have a specific plan for self-harm or suicide? Is the plan lethal, likely to cause serious harm? Description of the plan. Can the patient articulate the details of their plan? Access to the method. Does the patient have access to the means they intend to use? Mood changes. Observe for sudden shifts in mood. A change from sadness and depression to sudden calmness or happiness may signal an intention to commit suicide. Physical findings. Look for signs of harm such as lacerations, scratches, or scars. Search for harmful items. Thoroughly check the patient's belongings for any sharps or potentially harmful objects. Remember, assessing suicide risk requires sensitivity and thorough evaluation. Some warning signs that someone may be contemplating suicide. Talking about it. Expressing a desire to die. Feeling great guilt or shame. Believing they are a burden to others. Emotional state. Feeling empty, hopeless, or trapped. Extreme sadness, anxiety, agitation, or rage. Unbearable emotional or physical pain. Behavioral changes. Making a plan or researching ways to die. Withdrawing from friends, saying goodbye, or giving away important items. Taking dangerous risks. Displaying extreme moods. Physical signs. Lacerations, scratches, or scars from self-harm. Increased use of drugs or alcohol. When it comes to refusal of treatment. Clients have the right to refuse treatments unless they are deemed to have suicidal or homicidal intent. In such cases, treatment can be administered without their consent. If necessary, a patient may be petitioned to an involuntary treatment center. It is essential to understand the distinction between voluntary and involuntary treatment. Remember, ensuring safety and well-being is the priority. Guidelines and interventions for suicidal patients following discharge or in outpatient settings include the following. The person should have immediate access to support systems and be connected to a system of care, as the term hospital discharge is a high-risk period. Arrangements must be made for the client to stay with family or friends. If this is not possible, hospitalization should be reconsidered. A detailed safety plan should be developed that is an outgrowth of a comprehensive risk assessment and a collaborative, problem-solving discussion with the client. When implementing suicide precautions, consider the following steps. One-on-one supervision or close observation. Provide constant and close supervision to the at-risk individual. Documentation. Document behavior, mood, and any quoted statements every 15 minutes. Remove harmful items. Remove potentially dangerous items, such as glass, shoelaces, tweezers, plastic bags, razors, etc. Ensure visibility. Keep the client's hands visible at all times. Room arrangement. No private rooms. Keep doors open. Medication monitoring. Ensure the client swallows prescribed medications. Visitor restrictions. Restrict visitors from bringing harmful items. No suicide contract. Consider a no-suicide contract whenever applicable. Limit alone time. Limit how long time the client spends alone. The following suggestions are made for family and friends of an individual who is suicidal. Take any hint of suicide seriously. Anyone expressing suicidal feelings needs immediate attention. Do not keep secrets. Suicidal individuals are ambivalent about dying, and suicidal behavior is a cry for help. It is that ambivalence that leads the person to confide to you the suicidal thoughts. Be a good listener. If people express suicidal thoughts or feel depressed, hopeless, or worthless, be supportive. Let them know you are there for them and are willing to help them seek professional help. Many people find it odd to put into words how another person's life is important for their own well-being, but it is important to stress that the person's life is important to you and to others. Emphasize in specific terms the ways in which the person's suicide would be devastating to you and to others. Express concern for individuals who express thoughts about committing suicide. Familiarize yourself with suicide intervention sources, such as mental health centers and suicide hotlines. Ensure that access to firearms or other means of self-harm is restricted. Communicate caring and commitment to providing support. When interacting with someone who is suicidal, consider the following suggestions. Acknowledge and accept their feelings, validate their emotions and let them know you understand. Be an active listener, listen without judgment and provide a safe space for them to express their thoughts. Provide hope, offer encouragement and emphasize that things can improve. Avoid leaving them alone, stay with them or ensure someone else is present. Show encouragement, be supportive and compassionate. Seek professional help, encourage them to seek professional assistance. Remember, your support can make a difference. Evaluation of the suicidal patient is an ongoing process accomplished through continuous reassessment of the patient, as well as determination of goal achievement. Once the immediate crisis has been resolved, extended psychotherapy may be indicated. The long-term goals of individual or group psychotherapy for the client would be for him or her to develop and maintain a more positive self-concept and a sense of hopefulness. Learn more effective ways to express feelings to others. Achieve successful interpersonal relationships, feel accepted by others, and achieve a sense of belonging. A person contemplating suicide feels worthless and hopeless. These goals serve to instill a sense of self-worth while offering a measure of hope and a meaning for living. I hope you grasped the most important topics regarding self-harm, suicidal ideation, warning signs, and, most importantly, how to maintain safety for clients with SI and instill hope in such clients. I enjoy the rest of the week.